right, good morning. Thank you so much, Dr. Harlan. Thank you, Dr. Green, for that great talk. So I have to admit, I'm kind of nervous today because this is the first time that I'm giving a food allergy lecture with two very important people in the audience. One is my 13-year-old daughter, Karishma, and the other is my 16-year-old niece, Ava, who's watching virtually online. And both of them actually have an interest in culinary medicine. And I think it's just a testament to this, the importance of this concept of food as medicine, that our young people are so interested and passionate about this. So I wanted to start off with a question, and there's going to be a few interactive questions throughout the talk. How often do you think food allergies send someone in the US to the emergency room? And I know we don't have mics out there, but feel free to just shout it out. How often do you think someone goes to the ED in the United States due to food allergy? Daily? Anybody else? 100 times a day? All right, so it turns out it's every 3 minutes. That's astounding, isn't it? So just in the next hour, 20 people in the United States are going to present to the ED because of food allergies. So that really tells you that this is an incredibly prevalent condition, but also one that has a potential severity associated with it. So what are we going to look at today? First, we're going to understand the various types of food allergy based upon their underlying immunologic mechanism, and we're going to look at some trends and prevalence of food allergy. We're going to explore how to recognize and accurately diagnose food allergy. We'll look at some of the latest guidelines in terms of how we might be able to prevent food allergy, and also how we best manage allergic reactions. And then finally, explore some evolving treatments for food allergy. So starting off with, what is a food allergy? Well, the definition here, an adverse health effect arising from a specific immune response that occurs reproducibly on exposure to a given food. And there's a couple key points to this definition that are important to call out. One is that it has to involve the immune system. There has to be a specific immunologic mechanism that's part of this adverse health effect to the food. If it doesn't involve the immune system, by definition, it's not a food allergy. And then the second key thing is it has to occur reproducibly. So if someone had a reaction once to a given food, but then they eat it the next time and they're fine, by definition, that's not a food allergy. And so this just shows from the NIH food allergy guidelines a way to think about this. So you have adverse food reactions, and they branch into those that are immune mediated. That's where your food allergies would reside. And then those that are not immune mediated. And to give an example of something that is not immune mediated, that's a metabolic pathway, think of lactose intolerance. And so an individual who doesn't have enough of the lactase enzyme to digest lactose, they can develop GI symptoms with lactose ingestion, dairy product ingestion. They might think that they're allergic to milk, but they're actually not. That's a food intolerance and not a food allergy. And then on the food allergy or the immune-mediated side, the specific mechanism of that food allergy determines how it presents clinically. And so there are immediate reactions that can occur that are due to IgE-mediated pathways. IgE is the allergy antibody that is produced in response to a particular food. And when someone's allergic to that food, the food protein upon ingestion will cross-link the IgE on their mast cells, and then that causes the release of the allergic mediators that cause all of the symptoms. So that's immediate. And then on the other end, you have delayed reactions. And those are mediated through T cells, different part of the immune system. And an example of this could be gastrointestinal practice. Even atopic dermatitis could have a food component, and this is often a mixed pathway. So for IgE-mediated food allergy, what are the signs and the symptoms? Well, there are many body systems that can be involved. The skin can be involved, as you see here in these two pictures, with hives, redness, swelling of the face, swelling of the extremities. There can be mucosal itching of the tongue, the lips, the mouth. There can be swelling of the mucosa as well. GI symptoms, and so these are immediate GI symptoms of nausea, abdominal pain, vomiting, maybe diarrhea later on. There could be respiratory symptoms, both upper and lower respiratory, so rhinorrhea, sneezing, coughing, wheezing, shortness of breath. And then finally, there can be cardiovascular effects, such as hypotension, dizziness, syncope. So a true or false, and everyone can feel free to shout out what you think the answer to this one is. The prevalence of food allergy is increasing. This is an easy one. What do y'all think? True. I think almost unanimously everyone would agree that this is true. And we really oftentimes use the term the food allergy epidemic because of how much the rates of food allergy have increased over the past 3 decades. A total of 32 million Americans have a food allergy. And when you look at this by age, this equates to 1 in 10 adults and 1 in 13 children. And so the numbers really have skyrocketed. Looking a little bit more specifically at children, 8% of US children have a food allergy. That's about 2 kids in every classroom. So I think all of us will note that in schools, it's quite common that there are going to be children with food allergies, on average 2 per class. And of those children who have food allergies, 40% of them, almost half of them, are allergic to more than one food. And so it's not just anymore that a child might be allergic, let's say, just to peanut, but they might be allergic to peanut, milk, egg, etc. And 42% of those children have experienced a severe reaction at least once in the past. So true or false here, peanut allergy is the most common food allergy. What do y'all think? Who thinks true? Raise your hand. All right, who thinks false? All right, so we're a little bit split here. So this is actually true. It depends a little bit on age. So that was a trick question. And I think both of you, whichever way you answered, you could be right. Looking at peanut allergy, the rate of peanut allergy has more than tripled in the past 3 decades. And this is obviously associated with increasing healthcare cost and burden. So the rise in prevalence in such a short period of time would suggest that it can't just be genetics alone, that there have to be environmental factors. And so what can explain this? Well, it's likely multifactorial, and it's unlikely that we'll identify one specific environmental change that was responsible for this increase. But some of them, and these are going to look familiar to you based on our previous lecture, some of them are listed here. So improvements in sanitation seem to track along with increases in food allergy. The farm to urban migration, the prevalence of antibiotic use, especially early in childhood, dietary changes, so diets that are higher in fat, lower in fiber, do seem to track along with the increase in prevalence of food allergy. Again, increased prevalence of cesarean birth, and also increased prevalence of formula feeding. So what do all of these have in common? Well, they all alter the populations of microbes that live on and in our bodies. And so this concept of the microbiome is one of the areas that's being looked at quite heavily in research as a potential contributing factor to the increase in food allergy prevalence. So another true or false, food allergy can be outgrown. Who says true? All right, anybody say false? No, all right, so this one is correct. This is true. And it turns out the likelihood of a food allergy being outgrown is actually dependent on the specific food allergen. And so certain foods have a much higher likelihood of having resolution, and those include milk, egg, soy, and wheat. And you can see the rates of resolution, estimated rates of resolution listed here. One thing to note is that we used to think that if a child didn't outgrow their milk, egg, soy, or wheat allergy by school age, that it was going to be persistent. We now know that that's not true. And adolescents can, in fact, have resolution of their food allergy up to age 16, even after 16. Other foods, such as peanut, tree nuts, fish, shellfish, and sesame, are much less likely to be outgrown. And these tend to be lifelong. And you can see some of the rates here for peanut. Maybe only up to a quarter of children who have peanut allergy will go on to outgrow it. Even fewer for tree nuts, only about 1 in 10. Sesame, maybe about a quarter, and fish and shellfish, we don't have great numbers. The other thing to note with fish and shellfish is that those food allergies are more common in adults and actually can arise in people who have been eating seafood for their whole life and then develop a novel food allergy later in life. So this is going to now ask about how do we diagnose food allergies, because this is a huge area of importance. If a blood test to a food allergen is positive, that means the patient has a food allergy. Who says true? Awesome. This is false. And that means that thankfully the word is getting out there. With diagnosis, it's really the history that guides our diagnosis of a food allergy. And while tests for food-specific IgE are recommended to help with the diagnosis, they shouldn't be the sole means of making a diagnosis of a food allergy. And unfortunately, we see this all the time in the food allergy program, where patients are sent to us. Their primary care doctor might have done a panel of 20, 30 different foods for a variety of symptoms the patient may have presented with. And lo and behold, 10 of those foods are positive, and they happen to be foods that the patient was eating without any signs of reaction, but they were told, oh, you're allergic to these 10 foods, take them out of your diet. And obviously there's a huge risk to that in terms of the patient's nutrition and quality of life, as we just discussed. And so testing has a number of limitations. There's different ways that we test for food allergies. Skin prick testing, as shown here, involves pricking the epidermis of the skin to assess the local IgE response there. And it has a very high negative predictive value. So if someone comes in and the story doesn't sound very consistent with a food allergy, if we get a negative skin prick test, it's over 90% likely that they're not allergic to that food, and we can say, try it again. The specificity, however, is less than 100%, and there can be false positive results on skin prick testing. Serum immunoassays or serum food-specific IgE levels are also used to help guide the diagnosis. And these basically measure how much IgE antibody is present in that patient's serum against the specific food that's being tested. And the levels can range between 0.1 kilounits per liter up to over 100, well over 100. Higher the level, that correlates to a higher likelihood of a reaction, but it doesn't correlate to the severity of the reaction. And so you can take two children, let's say, who have IgE-mediated milk allergy, one of them maybe with a level of 20, one of them with a level of over 100. The patient with the level over 100 is not necessarily going to react more severely to a milk exposure than the patient with the level of 20. It just means that that patient with the level over 100 is much more likely to react in general with an exposure, but we can't really predict the severity of that reaction. We tend to use the food-specific IgE levels more as trends. And so over time, in a patient with food allergy, we'll check their IgE levels periodically, and that can help us track their chances of having had resolution of that food allergy. And then it will guide us in deciding whether to offer what's called an oral food challenge. And this is where, under supervision, we gradually feed the culprit food, and we watch to see if there's any signs of reaction that occur. This is the gold standard, the most specific test for food allergy. It can be used to confirm the diagnosis early on if it wasn't clear based on history or on testing. It can also be used, as I just mentioned, to assess for resolution of the food allergy. And then finally, elimination diets. And so sometimes, depending on the type of food allergy, it may be advisable to remove the food from the diet for a period of time, assess whether symptoms improve, potentially reintroduce it afterward to see whether they recur. So what are some of the pitfalls? I alluded to some of these earlier, but a positive test indicates what we call sensitization. That means that this person makes IgE antibody to the food, but it doesn't necessarily mean that they're clinically allergic to that food. And so the screening with indiscriminate panels, it's not informative, not advisable at all. And really the history of what happened should guide our selection of what to test. And if a patient is tolerating a food in their diet, that food doesn't need to be tested, at least as it relates to IgE-mediated food allergy. The other thing is that there can be false negative test results. And so if a patient has a convincing history of having reacted to a food reproducibly, but the testing is negative, that does warrant further evaluation, perhaps with a food challenge. And this could be because the reagent might lack the relevant protein that they're allergic to, or it could be a non-IgE mediated mechanism, like a T cell mediated mechanism is what we talked about earlier. So what's our current treatment? Well, we'll talk about evolving treatment, but as it relates to current treatment, most patients with food allergy, we advise them strictly avoid the foods that you're allergic to. That involves reading food labels, avoiding cross-contamination or cross-contact, and then obviously being prepared to react to allergic reactions with emergency medications. And so this is our next true and false, and this relates to allergic reactions. And so prior food allergy reactions predict how severe future reactions will be. So the idea here would be if someone's had a severe reaction in the past, that means that they're going to be more likely to have severe reactions in the future. Who thinks that's true? Who think that's false? Most of you say false, and it is false. So food allergy reactions are really unpredictable. And obviously the most severe reaction that we're concerned about is anaphylaxis. And so this is a severe, potentially life-threatening allergic reaction. And by definition, it has to involve 2 or more different organ systems. And so an example would be if patient ingested their food allergen and they started breaking out in hives, and then they also started having abdominal pain or vomiting, that's 2 systems, skin and GI, so that qualifies as anaphylaxis. Another definition could be that they've been exposed to their food allergen and they have fainting, they have symptoms of cardiovascular impacts such as reduced blood pressure leading to weakness or fainting. Now, a few of the myths, and so to tackle the first one that we just talked about, prior reactions actually do not predict the severity of future ones. Reactions are completely unpredictable. And there's all sorts of factors that play into the severity of an individual reaction. So how much of the food was eaten, so the dose, what form it was in. So some forms of food might be more allergenic or less allergenic than others. An example with milk and egg is that if it was in a baked form, it might be less allergenic than if it was in a direct form. And in addition, there are certain cofactors related to the patient. So was the patient sick at the time? With a fever or an infection, that will increase the risk of a severe allergic reaction. Were they overheated? So anything that increases the core body temperature, exercise, taking a hot bath, a hot shower, immediately after the food ingestion, that also increases the risk of a severe reaction. And so the bottom line is that even a patient who's had only mild reactions in the past can go on to have severe anaphylaxis in the future. Second myth is anaphylaxis always presents with skin symptoms. False. That's not true. And it turns out that 20% of anaphylaxis doesn't involve any hives, any skin symptoms at all. And in fact, 80% of fatal reactions have no skin symptoms. And that's probably because everyone was looking for skin symptoms and thinking, oh, well, it has to involve hives to be an allergic reaction. And they waited to give the epinephrine and the other treatment. And that obviously increases the risk of a bad outcome. So what are some of the risk factors for fatal food allergic reactions? Well, a delay in giving the epinephrine. And so that's why it's so important that all of our patients with IgE-mediated food allergy have access to 2 epinephrine autoinjectors at all times. And that if they start experiencing the symptoms of anaphylaxis, they don't hesitate and they administer that quickly. Age is also a risk factor for more severe reactions. Adolescents and young adults do have a higher risk for 2 reasons. One, they are more risk-taking with their eating, and so they do not always exercise care in avoiding their food allergen, and they're also less likely to carry their epinephrine autoinjectors on them. Asthma is also a risk factor, so patients with asthma are more likely to have severe reactions. And then depending on the food that the patient's allergic to, that might increase the risk. So in general, peanuts, tree nuts, seafood have a higher risk, but really any food allergen could contribute to a severe allergic reaction. So this is a emergency care plan that all of our patients, we make sure that we go over this with them, and we use the one from FAIR, Food Allergy Research and Education. And this can be accessed online at their website, foodallergy.org. And so you see on this action plan On the left side, it goes through all of the severe symptoms that would warrant use of epinephrine. And so breathing problems, being pale or faint, throat tightness or swelling, obstructive swelling in the mouth, diffuse hives, repetitive vomiting, or a combination of symptoms from 2 or more different parts of the body, all of those require epinephrine right away. Mild symptoms could be treated with antihistamine. So that would be, for example, a little bit of sneezing, runny nose, itching in the mouth, a few hives, meaning not diffuse, or fussiness, stomach upset that hasn't progressed to repetitive vomiting. But we always tell our patients after giving an antihistamine for mild symptoms, they always need to watch to make sure that those severe symptoms don't start coming on afterward, because if they do, then obviously they need to use the epinephrine at that point. So every minute counts. So what are the step-by-step things that we do and we tell our patients to do? So first, identify the signs and the symptoms, and then remove exposure to that allergic trigger. Inject the epinephrine immediately, and the dose is shown here. What's available in the auto-injectors are 3 doses currently. There's a 0.1 milligram dose, which is for infants, and then there's a 0.15 and a 0.3 milligram. 0.15 is the junior for patients 25 kilos and less, and then over that is the 0.3, the adult dose. This is given IM, not sub-Q, and the reason is because IM administration leads to a more rapid increase in the plasma and tissue concentration of the epi, and it's given to the mid-anterolateral the meaty part of the thigh on the side there. It can go through clothing, unless it's something really thick. Avoid like the seam of a pair of jeans, but we don't have to waste time taking clothes off because it goes through clothing just fine. And then activate emergency response. Now, during the pandemic, the guidelines shifted a little bit because we were trying to keep patients out of the ED. So we used to say, if you've used epinephrine, go straight to the ED. It was changed to say you could actually call your allergy doctor and find out what to do next. You know, they would tell you based on the symptoms, whether they're getting better, whether you need to go or not go. What's important is monitoring. And so after the first dose of epinephrine has been given, 5 to 10 minutes later, that second dose, if the symptoms are getting worse or they're not getting better, that second dose can be given in the other thigh. And if that is given, then regardless, we always say go straight to the emergency department for further monitoring. Positioning is important, something that we don't always think about. So after, as part of the management, laying flat with the legs raised to increase perfusion to the vital organs. There could be other positions that we use for vomiting on the side. If there's respiratory distress, putting the head up a little bit, but laying flat is important. And then, as I just mentioned, repeating the epinephrine every 5 to 15 minutes if the symptoms are getting worse or not getting better. And then the other medicines are given just as adjuncts. They're not replacements of epinephrine. And so the antihistamines, unfortunately, they're the most common medicines that are given in anaphylaxis, and they're the most common first medicine that's given, even with severe symptoms. And they're only going to relieve symptoms of itching, hives, but they're not going to do anything for airway obstruction, hypotension. They're not going to inhibit further release of allergic mediators. And then bronchodilators like albuterol, if there are symptoms of wheezing, then those are given afterward as well. But again, they don't relieve any upper airway swelling, hypotension, or shock symptoms. So avoidance. So how do we avoid food allergens? This is our next true or false. So with regard to avoidance, antibacterial hand sanitizer is effective at removing food allergens. And so there's hand sanitizer everywhere these days. Is that effective at removing food allergens? Who says true? This is false. So all the hand sanitizer does is it moves the food allergen around on your hand. It doesn't get rid of it. To get rid of food allergen on your hands, we need to wash with soap and water. And so that's an important point with food prep. So what about food labeling? And this is an important area because there are laws, and there was another newer law that I'll talk about in a moment, but back in 2004, FALCPA was enacted, and this said that all packaged food produced in the US had to identify in simple, clear language the presence of any of the 8 most common food allergens, and those are listed here. You'll note that sesame is missing from this. So this was the top 8, but it didn't include sesame. And it required that they be labeled, even if it was just additive or flavoring. It didn't apply to items that were regulated by the USDA or by the Alcohol, Tobacco, Tax, Trade Bureau. So things like meat, poultry, wine, beer, spirits, they were not included in this list. Excuse me. It also didn't apply to cosmetics, shampoos, personal care products, pet food. So those things are not required to be labeled by law. And so in 2021, the FASTER Act was passed with the intention of adding sesame to this list. Sesame must also be listed as an allergen. This went into effect in January 2023. The unfortunate impact of this was that many food manufacturers that never had sesame in their food to begin with started adding sesame to their food in order to adhere to this. And it's because they didn't want to risk there being a small quantity of sesame in the food by cross contact. And so they said, we're intentionally going to add sesame to the food and start labeling it as sesame containing. And so all of our sesame allergic patients contacted us, and there were products that they used to be able to eat all the time that all of a sudden now were listed as containing sesame. So a big loophole and problem with this FASTER Act. And so how do we read food labels? This is something that we spend a lot of time, and our dietitians spend a lot of time in clinic going over this with our newly diagnosed patients, because it's critically important for them to read food labels before they eat anything, any packaged food, to minimize their risk of having an allergic reaction. And the law just says that it has to be clearly labeled. It doesn't require where on the label, but it just has to be somewhere. And so sometimes it'll be in the list of ingredients, sometimes it'll be underneath in a contain statement, but it does have to say the specific food term. And so in this example, butter is listed in the ingredient list, but they had to call out milk in the contain statement. So you can't just expect that the individual is going to interpret that butter means milk. They have to list milk specifically. And so we tell our patients, read both, just be very thorough, check everything, make sure that there's none of your allergens listed. And if it is listed, don't consume that food. Now, this is another problematic area, precautionary labels. And I'm sure all of us probably have seen this on food that we're eating. And these are the may contain, made in the same facility, made on shared equipment, not guaranteed to be free of. These are not regulated by law at all. And so companies are able to put precautionary labels however they please. And sometimes it's just to cover themselves. There's probably negligible risk of the food actually being in that product, but they just put it on there to cover themselves. There have been studies that have looked at how many of these precautionary labeled foods actually contain enough food allergen to cause a reaction. They've looked at this for peanut and some for tree nuts, and it can vary depending on the study, anywhere between maybe like 10%, 15%, as high as 20%. And so we recommend to our patients, avoid those, call the manufacturer if there's any confusion, and then obviously discuss it with their provider before just trying the food. So how do we avoid cross-contact? And cross-contact is basically because such a small amount of a food allergen can contribute to an allergic reaction in food preparation, whether at home or outside of the home. If there's not safe cleaning practices, that food protein can get transferred. And so we obviously recommend at the home having separate places for safe and unsafe food, or allergen-free and allergen-containing food, labeling. So within a household, the patient who has a food allergy might have something that says that this is their safe food, this is their shelf, and everyone else in the house might use a different section of the pantry. Washing and cleaning. So have family members wash hands before and after eating. Scrub the surfaces after cooking and after eating, thoroughly clean cooking utensils and equipment between uses, and then create allergen-free zones perhaps. So some families choose that they're going to say, okay, we only eat in the kitchen and dining room, and we don't eat in the family room or living room because we don't want to risk food getting into those areas. There's also considerations with cross-contact and restaurants. And so there are certain restaurants that inherently are higher risk. And so we just tell our patients to be particularly cautious in those environments. That could include buffets, bakeries, ice cream parlors, even grilling or frying oil. So you may not think of it, but the same oil that was used to fry shrimp might be used to fry French fries. And so when ordering out at a restaurant, it is important for our patients to ask about the risk of cross contact through oil. Choosing a restaurant. So there's a lot that goes into planning ahead. And so for our patients with food allergy, asking colleagues, looking on the internet for restaurants that have a good reputation with managing food allergy, reviewing their menu online before going in, and then perhaps considering chain restaurants because their food prep might be a little bit more reproducible than others. And then calling ahead, as I mentioned, asking to speak to the manager, asking to speak to someone in charge of food safety, and then once getting to the restaurant, presenting, and I'll show it in a second, a chef card, explaining the foods that the patient is allergic to, asking about ingredients, asking about preparation, and separate utensils and equipment. So a chef card is something that we recommend, and this can be particularly useful while traveling. And so this time of year, a lot of our patients we're reminding them, get your chef card ready. It basically lists what foods the patient is allergic to and declares to the food service staff, I have severe food allergies. In order for me to avoid a life-threatening reaction, I must avoid all foods that contain. And then they list those foods. And then the statement, the alert is, please make sure that my food doesn't contain any of the ingredients on the front of this card, and that any utensils, equipment used to prepare my meal, including prep surfaces, are fully cleaned immediately before using. And so this can be translated into foreign languages if patients are traveling overseas. I particularly recommend it in that environment, just to make sure with language barriers that the restaurant knows what the patient is allergic to. So true or false? So now we're moving into the prevention part of food allergy. Feeding foods to infants too early increases the chances that they will become allergies. Who says true? Okay, I made these questions way too easy, I think. False. But that's good. That's good that we're getting the word out there about prevention. So this was a confusing area previously because the guidelines reversed. And oftentimes with medical knowledge, there's changes. As we learn more, the guidelines change. Back in 2000, it was recommended to delay the introduction of highly allergenic foods to decrease the risk of food allergy. This was wrong. This was not correct, but this was actually what many organizations recommended to our patients and families. Then in 2008, they said, well, actually, there's no evidence for delaying introduction to highly allergenic foods, and there's no guidelines about when to introduce them. Do whatever you want. That was 2008. Then in 2014, data became available that suggested that delaying the introduction of complementary foods actually might increase the risk of food allergy, and the early introduction might decrease that risk. And then in 2015, the LEAP trial, which we'll look a little bit more at, was the first randomized clinical trial of early peanut introduction during infancy and the later risk of peanut allergy. And the findings from that study led to a consensus communication about the early introduction of peanut. So this is the LEAP trial from Gideon Lack and colleagues in the UK. And essentially what they did was they took 640 infants who were at higher risk for food allergy between the ages of 4 and 11 months. And they were higher risk because they had severe eczema and or an already diagnosed IgE-mediated egg allergy. And then they randomized them into two groups. The first group ate peanut regularly until age 5 years. The second group avoided peanut strictly until 5 years. And of note, this included a number of infants, over 500, who actually had a negative skin prick test, but also about 100 kids who had a positive skin prick test to peanut. So some of these babies were already sensitized to peanut, but they decided to randomize them to peanut introduction. And these are the results here. So you can see that by the intention to treat analysis, looking at both the peanut sensitized and the peanut not sensitized group, both cohorts had a significant reduction in the risk of peanut allergy in the consumption group versus the avoidance group. And the relative risk reduction from the early peanut consumption was over 80%. And so as a result of this, the food allergy guidelines have continued to evolve. And you can see what some of the most recent guidelines in 2021 from our Allergy Academy, the Quad AI, from the American College, and others abroad. They recommend that for all infants, but especially those who show increased risk because they have some eczema, food introduction with complementary foods should begin somewhere between 4 to 6 months of age, and it should include potentially allergenic foods, such as peanut, egg, tree nuts, wheat, milk, etc. And in general, the idea is to get these foods introduced to the infant before about a year of age. And so to try to include that variety of foods, a diverse diet, because that does seem to be preventative. And then this question of screening is still somewhat unsettled. For certain higher risk populations, there are guidelines out there still that would recommend that they be screened with some skin tests or go see an allergist before the food is introduced. But most of us believe that that recommendation is probably going to fall off, and that for all children, screening may actually not be necessary prior to introduction. Just go ahead and introduce the food and see what happens. So finally, what are some of the evolving therapies? And so there's a need for novel therapies. I think it's obvious that the prevalence of food allergy has dramatically increased. The morbidity of food allergy is significant. We really don't have that great of a standard of care management to advise patients of. We tell them, avoid what you're allergic to, have your emergency medications, but there is a need for treatments of food allergies. Currently, there's only one FDA-approved therapy for food allergy, and that's for peanut allergy. It's called Palforzia, and it's a peanut oral immunotherapy product. And this, we'll talk a little bit more, but the idea with oral immunotherapy and with all of these food allergen-specific therapies is really to use the food as medicine. And I think it's fitting that we're here today talking about that at this conference. But the idea is to, in very small doses, begin introducing the food, either orally, that's oral immunotherapy, under the tongue, that's sublingual immunotherapy, or as a patch on the skin, that's epicutaneous immunotherapy, to help convince the immune system to become desensitized to that food protein and lessen the reactivity to the food. There's also non-specific therapies that are being investigated, and these can include biologic therapies, which we'll look at in a bit. There's a phase 1, phase 2 trial of a nanoparticle infusion for peanut. This has actually also been looked at for celiac disease. Something called fecal microbiota transplant. So this is going back to that theory that maybe the microbiome is what's responsible for food allergy. And if you replenished a diverse, adequate microbiome, could that help with food allergy? And even some integrative therapies like traditional Chinese medicine are being looked at in humans now to evaluate for food allergy. So this is a figure taken from a paper back in 2017 that just kind of broke out what are the different that we're looking at. Some of them are allergen specific, and in the allergen specific category, some of them involve using the native food protein, and that might include the OIT or the oral immunotherapy to milk, peanut, egg, etc. There are also studies looking at modified food protein, and that could be, for example, baking the milk or the egg, because we know that exposing the milk and the egg protein to high temperatures for a long duration denatures or breaks down the protein and makes it less likely that the immune system will recognize it. On the other side, the allergen non-specific, there are a variety of different biologics that are being looked at, as well as probiotics, and as I mentioned, the Chinese herbal remedies. So with allergen immunotherapy, all of it, as I said, relies on delivering gradually increasing doses of the specific allergens to induce one, desensitization. So desensitization is just a temporary increase in the reaction threshold to the food during active therapy. And so in the case of OIT, oral immunotherapy, patient is ingesting these small quantities of the food protein. While they're taking those, they're desensitized. They're able to eat perhaps a little bit more of that food protein. Now, the unfortunate thing is that desensitization requires ongoing ingestion of that food. What we really are hoping to find is something that will induce what's called tolerance. And so tolerance is the ability to ingest the food allergen without symptoms despite prolonged periods of avoidance or irregular intake of that food protein. And so with OIT, the recommendation is to have our patients take it daily. Well, what if they forget? What if they take it like 2 or 3 times a week? Or what if they take it daily, but then they stop taking it for 3 months? Are they going to still be able to ingest the peanut? That's the question involved with tolerance. And in research studies and clinical trials, we use something called sustained unresponsiveness as a surrogate marker for permanent oral tolerance. And basically, we give the treatment, we stop it, and then we do a food challenge after the period of avoidance to see whether they can still tolerate the food. And so this is a typical oral immunotherapy protocol where there's often a food challenge in the beginning to establish at what dose the patient reacted to the food. Then they have the updosing, where they're starting at the very low dose of the food, they updose, they get to a maintenance dose. That's your desensitization phase. Then they have another food challenge, and then they stop the food, they stop the OIT, and then undergo another food challenge afterward to assess for sustained unresponsiveness. With Palforzia, this just gives you a sense of the dose amounts that this particular product uses for the desensitization. It starts with a very, very tiny dose, 0.5 milligrams, and then it moves all the way up to 300 milligrams to give you a sense of where it starts. So 1 milligram is about 1/300th of 1 peanut. So these are like tiny, tiny doses of peanut protein. 300 milligrams, the maintenance dose, is the equivalent to 1 peanut. And so then they remain on that dose of 1 peanut. The intention with this treatment is not to cure the food allergy. Patients who have this peanut allergy, they're still advised avoid peanut, be careful with avoidance. But what this does is it makes it much less likely that they would have a reaction with accidental exposure. And so Palforzia, the clinical trial outcomes are shown here. And these are the patients who were able to tolerate each of these respective doses of peanut at the exit food challenge. Again, 300 milligrams is 1 peanut. So the patients in the Palforzia group, 76% of them tolerated that dose versus 8% in the placebo group. 600 milligrams is the equivalent of 2 peanuts. Over 2/3 in the Palforzia group versus 4% in placebo, and then 1,000 milligrams, 50 and 2%. And so definitely something that patients are thinking about. However, one of the main issues with these oral immunotherapy treatments is that they have a significant risk. And so we're feeding the food that the patient is allergic to. And as a result of that, there can be a risk of allergic reactions. In the clinical trials for Palforzia, for example, the most common adverse effects were itching in the mouth and the throat and GI upset. However, there were patients who experienced more severe allergic reactions, including anaphylaxis, that required treatment with epinephrine. And so there are some downsides with the immunotherapies. The risk, as I just mentioned, of severe allergic reactions, the lengthy updosing period, so this takes months, and it's daily ingestion with the every 2-week updosing visits under clinical supervision. The other downside with oral immunotherapy as it is right now is that often it's food allergen specific. And so there are some protocols that are starting to look at desensitizing against multiple foods at the same time, but most of it is being looked at one food at a time. And then perhaps the most important drawback is that it doesn't appear to induce permanent oral tolerance or a cure. And so shown here, sustained unresponsiveness or tolerating the challenge after withholding the OIT or the other form of immunotherapy after 5 years of peanut was 50% after 4 weeks off therapy and 15% after 6 weeks off. So we need therapies that have rapid updosing, that have a low risk of reactions, that have the ability to treat with multiple allergens at the same time, and that can induce permanent tolerance. And biologics are one of the areas that are actively being investigated. And these are some of the monoclonal antibodies that target particular parts of the immune system that might be helpful in decreasing the sensitivity to the food. So, and IgE, I mentioned IgE is the allergy antibody, and there's biologics such as omalizumab and ligelizumab that target IgE and are being studied either by themselves for food allergy or in combination with oral immunotherapy. There's also been studies of dupilumab, which is a monoclonal antibody that targets the IL-4 receptor. IL-4 is a cytokine very high upstream in the allergy pathway, and when you block that, you actually have a decrease overall in the allergic response, what's called the Th2 response. And then there are a variety of others that are in the pipeline for evaluation for food allergy. And so these are some of the ones that I just mentioned. Omalizumab has been looked at as adjunctive therapy for peanut, cow's milk, egg, OIT, multi-food, as well as monotherapy, and then dupilumab as well. So in summary, just to wrap everything up, food allergy affects 1 in 10 adults, 1 in 13 kids. The prevalence is increasing significantly, and this is likely related to a multitude of environmental factors. Diagnosis is really important, and accurate diagnosis relies on history. Testing food-specific IgE has a lot of limitations and can help, but shouldn't be used as the sole means. The current guidelines advise that we introduce common food allergens to infants early on, starting anywhere between 4 to 6 months of age as a preventative strategy. Managing reactions is really dependent on food avoidance and prompt treatment of severe allergic reactions. The one thing that I didn't include here for time was just the nutritional and the quality of life impact. And as part of our food allergy program, we have dietitians and psychologists that meet with patients because modifying the diet depending on how many foods patients are allergic to is significant, and also ensuring that they're getting adequate nutrition. But then there's a significant psychosocial impact of food allergy that our director of our food allergy psychology program, Dr. Herbert, is investigating actively. And then finally, therapies are evolving, including FDA-approved peanut OIT and other allergen-specific and non-allergen-specific immunotherapies, including biologic agents. All right, so thank you very much. Appreciate it.
Thanks, Dr. Sharma. If you want to stay a minute, Dr. Green, if you want to come up, we can kind of crowd together so the camera will pick us up. While we're doing that, a couple of quick housekeeping. We're going to be in the kitchens starting at 11:15. There are some fruit and snacks over at where we had breakfast. For those of you who are following virtually, we will be streaming the taste and flavor session by Barbara Camp today. Tomorrow we will be streaming the green sauces, and we'll be sending you recipes if you want to follow along and cook along tomorrow with the green sauces. For those of you who are here, these are the locations where you're going to be. Flavor and building, again, if you go to that gazebo in the inner courtyard, using that as your orientation, sort of towards the right, flavor building with Barbara Camp, oral allergy syndrome with the amazing Chef Leah Saris, baking in Food Lab 123, and then knife skills with Jay Judy. We will be back at 1:45 with a talk by Greg Harlan. Yes, I think he's probably a cousin somewhere way back there. And he's going to talk about culinary program building at University of Southern California, how they built their program, et cetera. And then at 2:45, we'll have a panel discussion with all of our chefs, culinarians, dietitians, our 2 speakers from this morning for about an hour. But I've got a couple of quick, easy questions because we've got a little extra time. I'm going to start with Dr. Green, if that's okay. This says, and I like this a lot, thank you so much for your talk. I can't tell you how many times clients will tell me their primary doctor or XYZ has told me to follow a gluten-free diet without proper testing. And the question is, what should I be educating my clients on? What tests should I be advising them to make sure they have for the proper diagnosis? And I know it's in your slide deck, but reiterating it is always good.
Yes, so it's very difficult after someone has started a gluten-free diet to diagnose celiac disease. You can't do it because everything normalizes. So we see a lot of patients who come along and they say, you know, I'm on a gluten-free diet, I feel better or I don't feel better. How do I know whether I have celiac disease? So what we do in that setting is we do the gene test, right? And if the gene test is negative, we say, well, you know, we stop. You know, you probably don't have, or we think you don't have celiac disease. You know, you could try ingesting gluten. If the gene is present, we'll offer them a gluten challenge. So we just looked at 220 patients that had a gluten challenge, okay? And only 15% had celiac disease. And that involved ingesting gluten for a period of time and then having an endoscopy. We know that ingesting gluten for a period of time might not alter the antibody levels. And we use the biopsy as a gold standard. You know, it's very difficult when someone has had advice from a medical practitioner like whom the patient has respected to then like take it apart. But, you know, you've got to take it from the patients how much they want to go ahead. But we will offer a gluten challenge. And then the question comes up, how much gluten for how long? You know, there's one study showing one slice of bread for 2 weeks will alter the biopsy, but that was not confirmed in another study. So, you know, one slice of bread is like 3 to 5 grams of gluten. So we'll get people, if they tolerate it, to go longer and longer, up to 3 months before we do an endoscopy.
So it's interesting because I had no symptoms when I was diagnosed, completely symptom-free. I was anemic.
You hear that? I had no symptoms, I was anemic. That's what people say, I have no symptoms, but I'm anemic. Or, okay, so.
Well, let me rephrase that. I had no GI symptoms.
Okay. Well, like if someone says to me, I had no GI symptoms, like that goes through there like there, you know. Yeah. That doesn't mean anything. And like it's interesting, they did a study in Finland. So in Finland, they know all about celiac disease. They did a study and they showed that in retrospect, people who said, I have no symptoms, after a year, they felt better, right? So it's hard to feel better when you didn't feel worse. So in fact, and symptoms are such a personal thing, like, oh, I thought it was normal to like pass gas every time, you know, I walked up the stairs or something like that, you know. What people regard as being nothing to other people is like a significant effect on their daily activities. I heard a lady said to me, like, I had to stop going to yoga class, right? Because she was passing gas too much. And so, like, she couldn't say to me, I was passing gas too much. I had to work out why she couldn't go to yoga class, you know. So you interpret symptoms different ways.
Exactly. In spite of that, I felt, you've mentioned how fast people feel better. I mean, within 2 weeks, I felt, I mean, I didn't know I felt bad. Yeah. But now if I eat gluten, if I inadvertently, which has happened a couple of times, I have GI symptoms. I get sick, you know?
So this is why one of the reasons why we're very enthusiastic to get patients a treatment, because like patients who had no symptoms, whatever that means, after they've been on the diet for a while, if they ingest gluten, they get outpourings of this cytokine, IL-2, they get nausea and they throw up, projectile vomiting. And so now we know that, and actually that blood test is going to be developed, or it is being developed in Australia as a test for celiac disease in people who are on a gluten-free diet. So, we'll get people to ingest some gluten, and then you draw a blood test at 2 hours, and uniformly this IL-2 is elevated. And that is thought to trigger the vomiting center to go boom, like that. So we see that more in kids than adults, but it occurs in adults, and it's probably a dosage phenomenon.
Most unpleasant.
We're going to have a med for you.
Why is it so hard to outgrow tree nut allergies? Are there any treatments that actually work?
Yeah, very good question. So we don't entirely understand the difference between those foods that are more likely to be outgrown versus less. Probably has something to do with the ability of the food protein to be modified. So with milk and egg, for example, I mentioned earlier, you can bake it. And even when a child shows up very allergic to milk or egg, we're able to get baked milk or baked egg into their diet often after a food challenge. And then that introduction actually helps accelerate the likelihood and the rate of their resolution. There's nothing that we can do to modify the peanut or the tree nut protein. In fact, if you heat those proteins up, it makes it more allergenic. And so you wouldn't want to do that. But in terms of treatments, there are protocols that are looking at oral immunotherapy for tree nuts, as well as sublingual immunotherapy. And then these biologic treatments, the benefit of those is that they're really perhaps not allergen specific. So regardless of what food a patient is allergic to or foods, the biologic therapy may decrease the allergic response to all of them. Or it may make it more tolerable for them to do immunotherapy to all of their food allergens at once. And so some of the companies that make these biologics are actively trying to get FDA approval. And it may happen, soon in the next couple of years, where we're then able to use these biologics to make it easier to start immunotherapy for a variety of foods, including tree nuts. But we don't have a great understanding of why some foods like peanut, tree nuts, fish, shellfish are more likely to be persistent versus others. One of the other things that could be related is aeroallergen sensitization. And for those who are going to be in the oral allergy session, I'm going to be there as well. There's this concept of cross-reactivity, where proteins in some environmental allergens are structurally similar to proteins in some food allergens. And so for tree nuts, oftentimes tree pollen allergens can be cross-reactive with those tree nut proteins. And whether that's perhaps driving some of the persistence, maybe. This is also the case with shellfish. And so for shellfish, there's a protein called tropomyosin, which is found in the shell of the shellfish. It's also found in the shell of the dust mite and the cockroach. And so if someone has cockroach or dust mite allergy, they might be at increased risk for developing shellfish allergy as an adult, perhaps. But then also that might be what's driving persistence to that allergen, because they're chronically getting triggered with their aeroallergen, the dust mite or the cockroach. So that could be part of it, but we just don't have a clear understanding yet of why the difference of resolution is there for different foods.
It's very interesting. I appreciate your talk very much. It's very interesting that a lot of the myths that get carried into celiac disease come from the allergy world.
Yes.
This myth that you've got to get new pots and pans and cooking boards and cutting knives, etc., is one of them. But we're doing a study now on kissing, because that's what people were worried about. Yeah. And so we're actually doing these kissing studies. We've had 4 couples already participate, in which one partner will eat something like 30 crackers and then collect saliva and then kiss, and it has to be a certain kind of kiss and everything like that. The dietitians and one of the doctors have done it, have celiac disease so far. And,
the IRB hasn't let us do the kissing study yet for food allergy.
The IRB
there might be a little bit more risk with that one.
We're in New York.